Good afternoon. I'm going to talk to you about myopic foveal schisis. There are many causes of loss of vision in a high myopia patient. Many of them are obvious: lacquer cracks, atrophy, posterior staphyloma, CNVM, a scarred CNVM, a large area of atrophy. But often the fundus looks normal, like this 60-year-old myope. A right eye was having very advanced degeneration with very poor vision. Left eye was his good eye with 6/9 vision. Professor of mathematics in Indian Institute of Science, a very learned person. So he was coming to me for follow-up, and his fundus looks normal, and we did an OCT. This shows some thickening of the posterior retina that you can see here. It looks at present as if there is some spongy thickening here. Patient's vision was 6/9. We followed him up. 1 year later, vision is slightly dropped to 6/12. Patient is slightly symptomatic, and then you can see that that gap has increased. So this is myopic foveal schisis, which is nothing but splitting of the retinal layers at the macula. Also, it is known as myopic traction maculopathy, myopic retinoschisis. Various names have been given to it to confuse. It was first described way back in 1958 clinically, but it was only in 1999 when the OCT became popular. We were able to really understand what is happening, and then that is how the myopic foveal schisis became a popular, well-known entity. Various studies have shown the incidence to be about 9 to 20% of myopic eyes with staphylomas. Females seem to be much more affected than the males. Most patients, like our patient that I presented, are asymptomatic. Some patients do present with reduced or blurry vision. Visual acuity may range from normal to reduced. Metamorphopsia could also be present. And exact etiology of this is at present still not completely understood. It is proposed that the relative stiffness of the inner retina compared to the outer retina due to staphyloma explains the formation of schisis. The outer sclera can stretch in a staphyloma. The choroid also can stretch to some extent, but the inner retina, which has non-distensible ILM and inner blood vessels, or an incomplete PVD that is often seen in these patients, does not allow the inner retina to stretch, and this may lead to formation of myopic foveal schisis. The OCT is diagnostic of this disease. Clinically, it is very difficult to diagnose this disease. So those of you who refer a patient of myopia for retinal evaluation, don't be surprised if we order an OCT in almost all these patients, because it's not possible to pick this up on clinical examination. You can see the early phase here showing mild increase in the retinal thickness with splitting in the outer layers. This is a later stage. You can see some column stretching in the schisic cavity, and you can see many of these patients also have an epiretinal membrane which is often present, and you can see foveal detachment, which is an advanced stage, and sometimes this leads to macular hole formation also. So that is a variety of pictures that you see on OCT. The natural course at present is unknown, but most patients may maintain reasonably good vision and may remain asymptomatic. But when the patient develops a drop in vision, metamorphopsia, most often this is correlated with detachment of the fovea and or development of a macular hole. In this prospective study of 134 eyes, these authors reported that 9% of patients with posterior staphyloma developed foveal detachment, and if there was no posterior staphyloma, none of them developed posterior foveal detachment. Presence of chorioretinal atrophy was also correlated with foveal detachment. The other factors with high risk factors for foveal detachment and macular hole were ERM, VMT, myopia of more than 10 diopters, and increased axial length. This is a patient whom we had treated in 2012, before that for myopic CNVM, and she was stable. In January 2013, she had a vision of 6/60 in her left eye with a scar due to CNVM and a myopic schisis. Since the patient was maintaining the same vision, we explained to her she did not really want any surgery. 2 years later, she came with a drop in vision of recent onset. Vision had dropped to counting fingers to 1.5 meters from 6/60, and you see that there is a foveal detachment and a macular hole which had developed in this patient. So this could be the natural course where the patient maintains reasonable vision, but once the fovea detaches or the macular hole develops, the vision drops. At present, management, generally if the patient's vision is good and if there is no foveal detachment, observation probably would be prudent, because at present time we do not have clear-cut data to determine the optimal time of intervention in these patients in whom the fovea is not detached. When the vision is dropping and when there is an obvious foveal detachment or a macular hole, surgery is definitely warranted, and various studies at various stages, they have reported that visual recovery is better in patients who have foveal detachment rather than in patients who have no foveal detachment. Surgery could be vitrectomy or macular buckling. I think the macular buckling is reserved for those patients who have macular hole with detachment, foveal detachment. And it is not a popularly done surgery, at least as far as I know in our country. Most of us do vitrectomy for these patients. We all agree that posterior hyaloid should be meticulously stained with triamcinolone and should be removed meticulously. Whether to do ILM peel or not, it is controversial, because there are some reports which say that peeling the ILM in this situation can cause macular hole formation in the postoperative period. And for this reason, an option that you could exercise is a foveal sparing ILM peel. One important point to note is that when you're planning surgery on these patients, if the patient has a very high myopia, you might need special long instruments to reach the ILM. We have had problems where we opened the eye and we could not reach the ILM. So please make sure that you have either long instruments, or you might have to go back to 20 gauge forceps in case you are not able to reach. Special long ILM forceps are available in order to reach these patients, the eyes which are highly myopic. You can very well see here, this is a OCT picture of a patient where if you do an ILM peel, this whole cavity may get exposed, and it's not difficult to understand why there are concerns about ILM peel in a patient with myopic foveal schisis like this. In this video, Dr. Naresh Kumar Yadav was good enough to lend me this video because I didn't have a good one in my own collection. You can see a scraper being used. Believe me, ILM peeling is the most challenging step in these patients because of the lack of contrast, ILM stains very poorly. You can see that he's using the scraper to lift the edge of ILM, and once you do that, then it's easier to peel the ILM. And once some part of ILM gets pinched and peeled, it is easy to distinguish between a peeled and non-peeled portion and continue with ILM peeling. I do resort to using brilliant blue under air in order to obtain a better staining of the ILM in these highly myopic eyes. And this is one step which is going to take a long time. It is the most challenging step in this whole surgery. Once you do that, generally you do a gas tamponade with a C3F8 with a face down positioning for about a week or so. This is a patient who came with finger counting close to face, and he had a foveal detachment, and post surgery you can see that the fovea is attached and the schisis is collapsed and the vision improved to 3/60. The other eye of the same patient 1 year later developed again progressive traction and myopic schisis with foveal detachment, and this we were able to do surgery at an earlier stage and patient could be maintained vision of 6/18. This is a table which shows results of surgery for myopic foveal schisis. Notice here that most of them have very small numbers. We do not really have large series reported in the literature to a great extent. And this table also has compared epimacular buckling with vitrectomy. And studies do suggest that the rate of retinal reattachment, especially in a macular hole with detachment, is higher when you use epimacular buckling compared to vitrectomy. However, as I said earlier, I do not have any personal experience with that, and I don't think it's a very popular procedure in our country at least. Very interesting paper I would like to end with. This is published in the beginning of the last year from China, where they looked at 112 eyes of 84 patients in whom they did vitrectomy, but they did not peel the ILM in any of these patients, and they have reported 95% success in collapsing the foveal Schisis cavity. So it looks as if you can get away and good results without doing ILM peel in these patients. So to conclude, macular foveal Schisis is an important cause of visual defect in degenerative myopia. We are becoming aware of this entity more and more now. As we do more and more OCTs for our myopic patients, we do pick up these much more. And it could be a slowly progressive disease. At the present time, we don't know when is the best time to intervene if the fovea is not detached. But if there is a foveal detachment or a full thickness macular hole, I think that's a definite indication, and we should offer surgery for these patients. And vitrectomy and epimacular buckling are the two surgeries which have shown good results. Vitrectomy is a commonly done surgery, and there is a controversy regarding ILM peel that I have shared with you. All the studies and our own hands, there is reasonable improvement in vision, and I think we should offer surgery for at least those group of patients who have foveal detachment or a macular hole with loss of vision. Thank you.